We have 12 on already. I've compiled our lists and our questions and our journey and all the things that we're going to go on.
Yeah.
So those of you who are watching, I have a necklace on today, and I'm curious to see what you see when you see this.
Makes me think of a tree branch.
Tree branch. Okay. So
upside down Y, some sort of Jewish symbol that I don't understand.
I'm not Jewish.
No.
So it's funny. My one child thinks of two hooves, like lamb hooves or horse hooves.
Oh yeah, I could see that.
Other child thinks it's a wishbone from Thanksgiving.
Okay. I can see that.
So this was my grandmother's, and when she passed away, she sent me a box of her jewelry, and this was one of the pieces that was in it, and it's made from coral, and it has little gold end pieces, so it's very cool. But when she first wore it, I was in college, and my mom was like, what is that you're wearing? And my grandma was like, I don't know, I just thought it was cool and it was a neat color. And I'm like, she's like, what do you see? And I'm like, I kind of see the internal iliac artery. And she's like,
yes, you do.
like, I was in college and it was our cardiovascular. So yeah, I see now. I can't not see the common iliac artery branching into the internal iliac artery.
It will be the common iliac artery. Yep.
So going with that phase, I think the theme of today is going to be, you can't unsee it.
Oh boy. Yeah, I got some stories from just the last 2 weeks, like you can't unsee it, but you go first.
No, I'll always let you go first, and I'll always just add my opinions at the end, because that's just the way we roll. But
well, there's two things I can't ever unsee. Okay. One is the vagus nerve. Yeah. It's like once you see everything that the vagus does, you can't ever unsee it.
Yeah.
But the other thing in the last 2 weeks has been vestibular injuries.
Wow. Yeah.
So I had 3 patients in a row who their complaint was neck pain, or I've had chronic fatigue for 20 years, or I've had, I'm just really EMF sensitive, and I can't eat anything, and I can't, I bloat up, and I'm constant constipation, and she really wanted to go through the whole story. It's like, no, just like, we can't go back to the beginning because I have all these other things I want to tell you. It's like, no, we actually have to go back to the beginning, because if we don't fix why all of these things have gone wrong since 1993, then what's the point?
Right.
Right?
Yeah.
So 1993, she had an auto accident and hit the windshield with her head, right? And then bounced back and hit the headrest. And ever since then, digestive problems, chronic constipation, esophagitis, just this sense of not knowing where she is in space, loss of balance, trouble reading. Sometimes she sees double, and she's seen all of these people that have given her really bad diagnoses with no data.
Right.
And why did this person say you had that? Well, she muscle tested for it. You can hear me rolling my eyes.
Yeah.
And then there's another patient where it's just that one side of his neck is really, really tight. Right. And it's like, do a vestibular screen, go back to when it started. Oh, I had multiple head injuries skiing, right? So all 3 of them, one of them came from New Jersey. And what was her original injury? Anyway, original injury was a blow to the head and mild concussion, right? From her symptoms, and now we have a brain injury visual symptom system checklist, and positive score is 18. Hers was 26. So before she saw me Monday afternoon, she flew in on Sunday, I sent her to Dr. Reski and I watched him do his exam. And she doesn't need corrective lenses, but he just put blank glasses on her and put the prisms in. And the first time she walked down the hall, she kept her right hand in her pocket, and it's her right ear that's bad. The second time, second prism in her left eye, her arms were stiff by her side. The third prism, her hips moved, her SI joints moved, and her arms swung.
Wow.
So all three of them thought they had something else, and they do have other things, but the vestibular injury was the missing piece. So there's one lady contacted me from Southern California, and I just looked up an FCOVD optometrist near her who would do prism glasses instead of vision therapy, because these patients, their necks are so messed up, they're not going to tolerate vision therapy.
Right.
So they wear glasses, the prisms, for 3 to 6 months, and then they can do vision therapy if they tolerate it. But with her, she wants to come up and see me. It's like, don't bother. Get prism glasses first, see what that fixes, and then we just work on your vagus, and about half of what you have will go away, and then you can come see me in 3 months.
Right.
So you can't, once you see it, you can't ever unsee it. I look for it everywhere.
Right.
How
Yeah,
about you?
I think, yeah, vestibular has been a big thing lately. And I think for those of you who are just joining us now, practitioners especially, we did talked about vestibular a lot last week, and I got a few comments rolling in about vestibular therapy and different screening tests and this and this. To me, it's not important for us to talk about it. There are experts in this area. It's not your role as a massage therapist or a personal trainer or a chiropractor to treat somebody with vestibular problems. It is your job, if you are in healthcare, to know enough to identify flags so that you can send somebody to that area. Because like you said,
Until you fix that, nothing else gets better.
What's one of your sayings about shooting holes in a boat, right? Like,
yeah, there's no point in bailing out a boat while somebody's still shooting holes in the bottom of it.
Right, or rearranging the deck chairs in the Titanic.
Well,
yeah.
And the other thing is that vestibular testing, like the patients that we get that have ligamentous laxity or neck injuries or whatever, they're not going to tolerate standardized vestibular testing, and it's expensive. It's $2,500, $3,000. So I just skip that. And if they go to an FCOVD optometrist that's actually recently trained, he'll be able to spot it and correct it, right, without having to do the rotary chair and the cold water and the hot water and the whatever. Right. And so, but the important thing for everybody listening and every healthcare provider, at the end of the 45 minutes that we do about vestibular injuries in the core and all the modules, our practitioners know more about vestibular injuries than 95% of the ENTs and neurologists in the country, not to mention GPs, every other medical specialty that diagnoses them with chronic fatigue or psychiatric illness. Okay, I'm fine now.
Yeah, it's so important for us to recognize it, to have people that you can refer to help treat it. And like you said, I mean, I think I don't have a lot of space for like jack of all trades, master of none. When it comes to healthcare and treating patients. I think you still look like the rock star if you can refer to somebody. As long as that patient's getting better, that's the main priority. So I get a little irritated when I come across chiros or PTs or massage therapists that are trying to do all of it. Be really good at what you do. If that's adjusting or soft tissue work, be proud of it, own it. That's great. But have somebody that can help you with, like you said, glasses, if you're going to go with balance work or proprioceptive work or vision training, whatever you want to do, but at least identify it. And at the very least, if you don't have the vestibular screen in your skill set, if you haven't taken the core, 94, 90, take the core. And we have so many, that's kind of on my list. It's been on the list of all the different ways people can take training. Because we have a lot of people that are listening to us who are practitioners who have not yet taken the core or the sports or any of it, that are thinking about it. So I think we've had a couple. Yeah, I think we've had some people interested in taking our stuff. So right now you can take the core virtual, right? It's all on the website. If you go to frequencyspecific.com, you'll see all the trainings listed. You can take it virtual, live stream, in person. There's options. You want to learn, we got a way to teach you.
Yeah, in person in February, but I think the best thing has been the 5-day core that we filmed in December, and Kevin has transcribed it. So you have everything that comes out of my mouth. And he said, do you have any idea how many sentences you start with so? I went, no. So then what do we do? So, yeah. Hello, A.
Yeah. I don't say that anymore. It took me about 5 years, but no, once in a while it pops up if I'm talking to my Canadian friends, but.
So we have the 5-day course. You have the 5-day video. We've got the 2 3-day modules, the one that you and I did, the pain and injury, and then the neuro and visceral. And there's something there for just about every skill set. Before we move on from vestibular injuries, I have to tell you, at the advanced this year, we have my FCOVD optometrist who's going to be lecturing. I can't remember if it's 60 or 90 minutes. That's my job this week, is to get that schedule finished and everybody up and running. But he's just a genius at what he does. And he'll talk about how to recognize it, not how to treat it so much, but basically how it works and why it makes such a mess of people's lives, what disequilibrium feels like, and why people have trouble reading or using a computer, or why at the end of the day they're so exhausted and they have a headache after they try and read, or if they do whatever. So it's I'm really excited about that part of it. Yes,
I'm excited about that too.
Yeah.
Continuing on with our courses and our education, this is also we have such organic segues. We couldn't script this. Like, for people who are listening and watching, like, we have no plan. Like, what you see is what you get. There's there's one take, it's now bloopers and all, and we're rolling with it.
Live.
Right.
There's some sort of mind meld though, right?
There always has been.
Yeah. Yep, always.
So continuing with the segue about our courses, I had somebody write in via Instagram who is a patient who has seen a few, that was in quotes, a few different FSM practitioners for her injuries, and received 3 very different treatments with 3 very different results. Why is there no continuity between FSM practitioners?
Oh, that's my fault. That was my core decision. FSM is a tool for a practitioner to use within their training and skill set.
Yeah.
It's not a recipe. But it took me until a year ago to figure that out. For 20 some odd years, I thought I was teaching people frequencies. Then I figured out that 50% of the course is diagnosis. If leaning forward makes it worse, it's a disc. If leaning backward, it makes it worse, it's a facet. If they have full body pain, shoulders, elbows, knees, feet, hands, if they have full body pain, it's inflammation in the spinal cord. But I think what happens is that people hear and see things through their own lens. And I have had practitioners who've taken the core First time she took it was 1998. The last time she took it was 2014 or 15. She took it every year in Portland. Every single time she heard something different, she learned something different. So you hear and learn only 20% of, if you go to a meeting or listen to a podcast or a webinar, you remember about 20% of what's said. So which 20% are you going to use? You'll use what you're comfortable with. And the problem with FSM, not FSM, problem with patients is that they come sometimes with a list of diagnoses that they're attached to. And I purposefully make them not give me their diagnoses. I'm not interested in what those other 6 people said you had, because if they were right, you'd be better by now. So let's pretend that those diagnoses don't exist, and let's just talk about your symptoms and when they started, and then what happened, and then what happened, and then what happened. So there's a chronological history. Not everybody has that much time. Not everybody has the same understanding of how the systems work together and what causes what. So it's FSM is a tool. It's not a recipe. It's not like baking a cake. That's,
I wish it was.
wouldn't it be nice?
And I think a lot of practitioners are still wishing for that, because if you go on the FSM practitioner page, you will see people asking for the formula, the list of frequencies. And when you see the replies, it varies so much because we're all kind of bringing our own, like you said, skill set, background, and mileage, so it's one thing when you just take the core and you've got your 20% in your forebrain that you're like putting out there. Those of us who've been in the trenches with it a decade, 15, 20 years, you kind of know what works and what doesn't. And again, it's fantastic when you are at the advanced. And I remember the first time being at the advanced, just sitting in the ballroom and just listening to all the different pockets of conversations. And you'd have the MDs talking about stuff, and the naturopaths and the acupuncturists, the chiropractors, the trainers. And
Jeez.
you'll never be like I've never been at a conference like that in my entire life. Veterinarians, like who we're all using the same tool and in such different ways. And, how you can teach something to so many different people is, I never got it until I started teaching myself. And the reason why,
I did warn you.
You tried. You tried, I know.
Oh.
But what I love about teaching the sports course is it's like the easy route, because the people that are there, they all have the same background. We all speak the same language. I get that these trainers cannot sit for longer than 20 minutes. That's why there's 6 practicums, and, we're jumping and flying off of tables and all that stuff. So when I read that question about, I saw 3 different practitioners and I got 3 different results. At first I was like, I'm sorry. And then I thought, but how cool? Because this tool was utilized in 3 very different ways, and we all saw something different. So to your point, yes, the core is a lot of diagnostic tools. And I remember it was 2012 or 13 that you came to Canada to teach it. And we had a big group of chiros and PTs. It was pretty much physical medicine. Yeah. And I remember 2 of the chiropractors, we got to like the last day, and I think it was visceral stuff. And he got up to take a phone call. I'm like, you need to go back and listen to this. And he's like, I don't treat viscera. I'm like, of course you treat viscera. Do you treat hip flexors? He's like, yeah. Then you treat viscera. What's the matter with you? Get back in there. And, but it's like selective, because you think I don't treat it, but of course you do. And then that's when it dawned on me, for the manual therapists out there, when you think you're treating the psoas, you're not treating the psoas. Think
Ever.
about all the layers. You're never palpating. You can't palpate psoas. You're palpating the stuff on top of it. And
well, and it took me until probably after that course to add in the part about scarring in the ureter, between the ureter and the psoas, is that's how to release this. It's never not the ureter. It's never not the kidney. Some patient comes in and his QLs are tight up at T10, 11, L1, and it's like, it's the kidney. It's like, no, it's the QLs. Everybody's been needling my QLs and they've been doing this and doing that to it. And it's like, yeah, but that's the most stable part of the spine.
Yeah.
There's no reason why your QL between T9 and L1 and L2 should be a rock only on the right. Does that make sense to you?
No.
And then the patient says, oh, yeah, no, okay. So have you ever played football in college? Have you ever been speared in the back with a helmet? Oh, yeah. And what do you do for your personal sport? Oh, I ski. You ever fall on your back? And he looked at me and just like, of course.
Yeah.
So you bruise your kidney and there's a little bit of, all it takes is a drop of blood. So that's of course you do that. The other thing I want to say to the patient that said, I saw 3 different practitioners and had 3 different outcomes. If she was only with each practitioner 1 or 2 sessions, everything comes in layers. So you treat, even I do, I treat what I find first. I make my best guess. I'm lucky because I've got 4 or 5 machines on a patient at one time. So I'll treat the vagus, treat the cord, treat the tightening in their legs. That's 81 and 10. They're all wound up because of the chronic pain. So that's 40 and 10. You have another one that's on vagal tone because that quiets down the midbrain. And then you can work on whatever they come in with. That's 4 machines. That's one treatment. But they come back that day or the day after, and you treat what's left and you find out what worked and what didn't work.
Right.
So it's like, don't decide that it didn't work until probably twice a week for 4 to 6 weeks. It takes about 4 to 5 sessions to figure out what's going on and what the compensations are. Because once you get, as you know, once you get the hips moving, then all of a sudden the knees and the calves and their right shoulder is now all lit up.
Yeah.
So, yep.
And I think that's a really important point that we have to continuously drive home to our practitioners is expect like poop to hit the fan.
Okay. Yes.
You know, this is never a smooth journey. And as long as I've been doing it, it's not like this smooth, slopey type of treatment. We're creating a lot of change and things happen really fast. So
short period of time.
Totally. So my my lumbar stenosis disc patient that comes in doesn't have back pain anymore, but she's got some weird sensations happening in the medial part of her knee. Well, because we stabilize the back and the glutes and the hips and the pelvis are moving, it's changing the tracking, and you know, but it all happens fast. And instead of freaking out going, oh my God, I made you worse. No, I've created knee pain. No, it's like, yay. My patients are like, what? I'm like, yay, you have knee pain. They're like, I don't understand you. I'm like, well, because your back is better and your hips are stronger and your core is getting stronger. And now your knees have to get the memo. So yeah.
Yeah. And sometimes now that this part is moving, now L3 has got an opinion about its new role. Yeah. And the L3 nerve root refers to the medial knee. So is the medial knee L3, L4, the muscle, the medial meniscus, or actually the knee? So there's 5 things it could be. And I'm with you. Oh, goody, your back's good. Hey, let's fix your knee.
Yeah. Like I think Yeah, FSM changes so much of what we do, and so rapidly. And so especially for the new practitioners out there, that I think that overwhelming sensation that we all get on the plane coming home from the core, and your brain is just like ready to explode. And then you have that moment of panic going, but now what do I do with it?
Yes, I'm really sorry.
Yeah, it's that you're welcome and I'm so sorry. So, and the core has changed so much in such a, like every year it changes. So one of the questions it was from somebody that took the core, she said 8 or 9 years ago. Is it worth redoing?
It's completely changed in the last year.
Yeah.
Because, especially, but 8 or 9 years ago, it changed every year. As I found, you teach it, let's say in February, and by September of the same year, you get on Facebook or you get emails from practitioners and they're asking questions, and it's like, well, saying it that way didn't work.
Right.
Let's try something else. So what I found out is I had to put in more detail. I had to have it all in writing so that they could look back. And then this year, because of COVID, I wasn't on a plane for 18 months. That's the longest I've been at home in 21 years.
Right.
So we have pictures, we have more, and I learned a lot from your slides. I even borrowed one of them, the cat, and sitting in the tree. Are you okay?
I'm not going for help.
No, I just curious. So the core has completely changed because I finally figured out that what we're teaching is how to look at what's going on with the patient when you have frequencies to use as a tool. So if you're a manual therapist, it would never occur to you that this tight muscle is not the problem. You feel the muscle, so you think it's the muscle. It's never the muscle. Apologies to David Simons. It's not, and many people, it's never the muscle.
Right.
So unless you had a way to treat adhesions between the kidney and the kidney fat pad and the QL, or between the ureter and the psoas, or between the nerve and the fascia, unless you had a way to treat that in 15 to 20 minutes without pain, without surgery, unless you had a way to treat that, it would never occur to you that that's what's causing the tight muscle, right, or the back pain, or the motor discoordination, right?
Right. Yeah, it's true. That's, to that point of when that chiropractor left the room, I'm like, get back in there. I don't treat the viscera. You do. And if you didn't, you do now, because you have to.
And it was probably after that meeting that I added the visceral section to the musculoskeletal section.
Yeah, but it's like you said, it's never the muscle,
Really sorry.
No, but I think the best practitioners that I've ever seen personally and do the best with this type of training are the ones that are always thinking that anyways. They don't just say, oh, you have bicipital tendonitis. All right, let's treat that. No, why did that biceps tendon get like that? Yes. Because the subscap was scarred down and the subscap doesn't move. And if you know something about scapulohumeral rhythm, the arm can't move without the scapula rotating. So let's treat the subscap. And now we can. So yeah, and again, once you see it and you start thinking like that, it is impossible to treat it any other way.
Yeah.
Like you can't. Yeah.
And exactly. The patients that come in and say, oh, they took off the end of my acromion because I had supraspinatus tendonitis. That's a good face.
Yeah.
That's like, oh, and taking off the end of the acromion made more space, but the bone bleeds and that makes more scar tissue. Oh yeah, so they took out the bursa too. Oh, okay. Okay. Yeah. So those are sometimes the most difficult patients because they had a surgery they didn't need in the first place that created problems that you then have to repair. And then you still have to go in and fix the original problem that should have been fixed in the first place. And then you can go back, and then the biceps tendon's easy. That's 124 and 191. It's like, that's easy.
Right. But that sequence was, you can't start with 194. I mean, with 124 and 191 torn and broken in the tendon, because the tendon didn't get torn from space.
Yes. You get a piece of chocolate if I put it through the
catch it. I want to talk about 18 for a minute, frequency on channel A. I see a lot of questions about it, using it in the subacute and chronic phases, and if we do, and why is it not just an acute frequency?
It's used anytime you want to stop bleeding. And that's usually in the first 4 hours for sure. And often in the first week after a surgical procedure or a trauma, right? So the arteries, capillaries just leak. Yeah. And the only time I end up using it in chronic injuries. So 18 is the frequency to stop bleeding, 62 is the love it. 62 is the artery, or 162 is the capillary. So you want to stop bleeding. The only time I ever use it in chronic injuries is where I'm doing manual treatment, especially in the viscera, but I've had it happen when they were rehabbing my left shoulder after the fracture. And we were doing a lot of getting rid of the scar tissue caused by the fracture and the surgery. I walked out of the PT place with my pain at a 3-4, which is just fine. I get out to the car at the curb and the pain is up to a 7-8, kind of nauseating. And it's like, oh, that's bleeding. So I went back in the clinic and just went in one of the rooms with one of the microcurrent machines, put 18 and 62, stop bleeding in the artery, held the gloves in my hand, put one contact on the shoulder where they'd been working, and the pain dropped back down to a 1. So in the process of breaking up scar tissue, it's really, especially in the abdomen, it's really easy to just tear a little blood vessel away from the fascia that's surrounding it, or the scar tissue that's gluing it. So that's the only time I ever use it in chronic stuff.
Yeah, I agree. I have this as part of a slide in the sports course. It's part of like my practice management kind of section about how to use custom cares for clinicians, especially chiropractors that are used to seeing like a patient every 10 minutes who think they don't have time to use FSM or they need to train an assistant. Yes and no. So if you are a chiro or a PT or a massage therapist, anybody, manual therapist who is doing deep tissue work and you are releasing a lot of scar tissue, especially if you're doing really deep aggressive treatment, it's really easy to set up just have a 18 and 62 set up on a custom care and have them sit, in a recliner or in another room for like a little post-treatment. I always tell my patients, I need to let you marinate for a couple minutes over here. So, and it just kind of helps that aggressive treatment if you are releasing scar tissue, like you said, especially in the viscera, or people who go really deep through the psoas. It is, I think.
And actually the hardest part, I think, in the practicums are people who are used to doing aggressive, deep tissue work, is to get them to slow down, feel what's changing. Yeah. And you catch more flies with honey than you do, right? Yeah. So be gentle and follow the frequencies down. What you think is scar tissue is not always scar tissue. I had that patient a couple of weeks ago where he had a history of a bunch of surgeries and things that were done to release scar tissue in the nerve. And I went after it, believing him and treating scar tissue in the nerve. And the thing that worked was torn and broken in the tendon. Because the muscle was tight and the nerve was scarred because what everybody was trying to do was stretch him, and the muscles were neurologically tight because he was 81 and 10 and his legs were just like rocks. And that creates tendinopathies. So they kept going after adhesions in the nerve because the muscles were so tight. And it's unpeeling it. And the thing that told me it was not scarring in the muscle or scarring in the artery was at scarring in the nerve. The thing that told me it was not that was that 13 and 396 didn't work. Didn't do anything.
Right.
If anything, it made him worse. It's like, okay, so let's try, right? And at the end, you run stop bleeding and increase vitality. But I think the biggest challenge for manual therapists with FSM is to learn to trust the frequencies. Treat inflammation in the nerve and see what happens to the muscle.
Right.
Treat inflammation in the cord and see what happens to the muscle. Treat torn and broken in the tendon, what happens to the muscle.
Yeah.
So the frequency response will teach you what's going on.
Right.
That only took me 15 years to figure out.
Well, how would you know? Right. I mean, one of my things I'll tell practitioners who have taken the sports or taken the core and contact me about, I can't feel it, whatever, sit down with your patient. And I love using the MFTP short protocol for this because it cycles through a lot of the main heavy hitters that you'll see in a traditional myofascial patient. Let it go on the custom care to have a patient take a deep breath and just feel. And when you feel something change, look, see what's on the custom care. It can be such a good learning tool and diagnostic. And then you don't have to worry about anything, but it does change the way that you palpate. It changes the way that you treat. I had a trainer who took the sports course a couple of years ago. We were doing our C-spine practicum and our supine shoulder, and the fingers were tight and the muscles and I was just like, stop. And everybody looked, I'm like, back away from the patient. He's like, what? I'm like, stand up and back away. And I'm like, you need to take a deep breath, relax your hands and your wrists. And I go, I shouldn't see this big vein in your bicep popping out. He's like, but her neck's so tight. I'm like, it's not your hands that are going to smash it apart anymore. Trust the frequencies, listen to it. And if it's not working, that doesn't mean you get to press harder. That means you change the frequencies. Your touch stays the same.
The first 5 years, that was my solution, was press harder. It took me 5 years and 50,000 patient visits to figure out that it's like, you just relax. So the words I use with people that are all fingers and claws is relax your wrists, relax your fingers. No, really, relax your, no, really, relax your fingers. The more motor impulses you have going out, the less sensory you have coming in. You just paid $6,000 for this machine. Why would you try and work without it? So what you do with a custom care, I do with a precision care, because it teaches me instantaneously, nope, that's not it. Change the frequency. Oh, that's not it. Change the frequency. Oh, it's a periosteum. Okay.
Yeah.
So less motor out, more sensory in, and you can feel the softening. And relax your wrists, relax your fingers. The other instruction that I think works is close your eyes. Close your eyes and then put your eyes at the end of your fingers, right?
Yeah.
When we work with Tom Myers, he's a musician. He sings, he plays guitar, he's all into sound. And he said, I hear with my fingers when he puts his hands on somebody, he can hear the tissue talking to him.
Yeah.
For me, because I'm a visual learner, put your eyes at the end of your, and usually when I say that, and I force them to relax the wrists, relax, then they get it. And once you see it, you can't unsee it. That's once they do that, I don't ever have to worry about them again, because they will never not be able to do that. They may have to practice it for 2 or 3 years.
Right.
But
It's that once you feel smush, you can never unfeel it. And that makes you a believer, right? And that's always my goal when I'm teaching a sports course, is that everybody can experience it as a patient, something releasing without somebody's elbow in them, and to palpate when something lets go. Because to me, that was my hook. I believed in it. I saw enough results with athletes that I knew this was legit, but it wasn't until I felt smush, and it wasn't because I pressed harder, and it was seconds into a treatment, I was just like,
whoa.
What the, and then it was like, I got to do that again. And then, then you get greedy, and then you get, yeah.
And then I've had practitioners email and say, what's the frequency that creates smush? What's the frequency that gets patients stoned? Anytime you run a frequency that the patient actually needs, the tissue will soften. And that's Juliana Mortensen's presentation at the symposium in 19. And I think in 21, but it was the one in 19 that just knocked my socks off. And then Jim Oshman's article on tissue softening with the use of frequency, completely different models for why it happens. But they have both experienced what smush is. So trying to explain the neurology or the biophysics of it is an entirely different thing. But it's different for everybody. And I'm really sorry. And thank you. Or you're welcome.
Welcome, and I'm sorry. Couple more questions here as we're rolling, because we always seem to run out. And there's somebody that put something in the chat that I also have that question. We got it emailed to us, so we'll make sure that we get to it for sure. Because if you're asking it 3 different platforms, you really want to know the answer to it. So we will totally get to it. Are there any other frequencies besides 124 that you feel are time dependent?
Well, we know for sure that shingles is time dependent. It's unfortunately, it takes 2 hours. That's the thing. 40 and 10 is time dependent. That takes 60 minutes. 40 and 396. So 40 and 10 is inflammation in the cord. And we know that the pain recedes from the feet up, and the neck and shoulders go last. And they go usually in the last 10 minutes of a 60-minute cycle. So in the new clinic that we're getting, I got leather recliners, glider recliners.
Yeah.
And that's for people where you just need a wrap around the neck, wrap around the feet. I'll be back in 60 minutes. Yeah. Punch the button, leave the room, because that's what it takes. Same thing with 81 and 10, actually. But they have loss of descending inhibition. And what everybody treats them for is that their quads are really tight. And their adductors and adductor brevis, especially, and the pectineus. And 81 and 10, Ben Catholi or Dave Burke or somebody is going to have to explain to me why it works this way. But the muscles soften up the front first. And what you thought was the quads and the adductors, if you reach around the knee, you find out that it's actually the hamstrings. So it goes up the front, quads, hamstrings. Once the brevis and the pectineus let go, then the trunk goes pretty quickly. The arms go quickly. That's with 81 and 10, increased descending inhibition. And then the hamstrings, the gastrocs and the soleus the hamstrings, the glutes, the QLs. It goes up the front and then it goes up the back. And I have no idea why. 40 and 10, I understand why, because it's feet first, because the homunculus, I assume it's something similar in the descending motor pathways.
Right.
And shingles, 40 and 396 is time dependent based on the length of the nerve. So inflammation in the nerve, in cervical nerve roots. So C5 is a matter of 20, 30 minutes. C7, 6, 7, 8, those are 45 minutes. The sciatic is longer. It's just a longer nerve. So it takes longer. And I really want a squid axon. I mean, not an actual squid, but a squid axon, and somebody with a laboratory that can tell me what we are doing to these nerves.
Right.
Why is it time dependent? Why does C2, which is just up the back of the head, why does that nerve take 20 minutes?
Right.
Why does C4 and C5 take 20 minutes? Why does S1 and L5, why does that take 60 minutes? I don't know, but it does.
I'm going to add a follow-up. I'm going to add a fake question here because I know this is coming, because this typically comes. So when we have practitioners that are new to this and they want to know, well, how long do I run something? Again, it's not a formula, and they're waiting for Smoosh and they don't know if Smoosh is happening or not. And they don't know how fast to change the frequencies. And if something takes 20 minutes, do we just let it run 20 minutes and then change it? So like, I hear all these questions coming now because I'm teaching it. So I will add, and you can correct me if I'm wrong. If 40, thank you, but it happens. 40 and 396, the pain will start to go down almost right away. So that's how you know you're on the right track. Tissue will get warm, it'll smush. They'll be like, oh, I think it's something starting to happen. That's how you know you're just hang out a little bit longer on it. And then that 20 minutes is what it takes to kind of finish the job to do what it needs to. Is that?
Yeah, exactly.
accurate?
And it's the same thing, actually. I forgot to mention 124 and
Right.
7. So torn and broken in the connective tissue, the pain goes down almost immediately. It starts to drop. Oh, that feels so much better.
Yeah.
But in order to actually repair the tendon, it's like, do you have anything important to do in the next 60 minutes? Because we can make a lot of headway with this if we actually repair this tendon.
Right.
Okay, yeah, I can wait. So then you have to decide, is it a round tendon or a flat tendon? So that's when you haul netter out.
Yeah.
And so 124 is time dependent, but the pain, it's easy to get suckered because the pain drops in seconds.
Right.
But in order to actually repair the tendon takes an hour. So I learned that when my tendon was the one that got repaired. When my Achilles,
Yeah. So yeah, don't give up on it. Don't bail too soon, but give it time to do its thing. And yeah, I can't think of anything else besides cord, nerve, torn and broken that needs shingles. I think that's it. It's funny, for a while I thought the 58s might be time dependent because I didn't think they worked. And then I let those suckers run and run and run and run. And then I was like, no, they
don't work. So practitioners that took the course 15 years ago say, what happened to the 58s? Kim and I decided they don't work.
I'll never forget sitting there doing the slides and looking at it. And then I think you had said, what do you think of the 58s? And like, part of me didn't want to like admit that I was doing drive-bys on them and I wasn't like giving them a chance. And I remember just looking down, being, I don't think they work. And you're like, thank God. And I was like, yes. Because I really wanted them to work because everything worked, so I tried it every which way, and
one place they seem to be important is in the viscera, is in the
okay.
belly. So 13 and 77 for sure.
Yeah.
But 58, 02 and 32. Abrams was onto something, and they work in the belly. sometimes, but most of the time I've just given up on them. Back in the day in 97 or 98, when Ryan dug them up out of the rare book room, they were a game changer, but over the years, they're just not getting it. So sorry.
Yeah, interesting. Okay, I'm going to pull up that one question because we need to have it. It's not there.
Paula, how long for hypoxia to work? That one's yours because hypoxia is your friend.
I love it. So I find that you have to almost layer hypoxia, something that it's almost like when you see a really old chronic injury, you can feel it. It feels like beef jerky. So anytime you're thinking of using something that was calcified, something that's been around for a long, long time, again, the results will be instant. I don't think this one has to run very long. I've run it, I put it on people's custom cares. I usually max out around 4 or 5 minutes, because once you've released the scarring, it's almost like it just makes sense to try to give it a little extra oxygen, because, you know, frozen shoulder or anything that's been scarred down for so long, it hasn't received proper blood supply or neurological, it hasn't received anything. So a few minutes and you can easily get some results. I've seen hypoxia to to help a patient with Lyme. Oh, makes sense.
Kind of makes sense.
Yeah.
There's another one.
So it's on the Q&A maybe. Here it is. Oh, here.
That one.
Let's go back up here. This one is an 18. If 18 can be thought of as stop leaking, is it ever useful in acute disc herniation, as in 18 with 330, 630, or 710?
I've never used it that way, but it's worth a try.
Yeah.
So this is, remember the part in the core where we say it's not like we know what we're doing? This is it. It's like, this is FSM is clinical research in real time. So Lorena, if you remember the little bird on your shoulder that talks to you and says, I wonder if the disc can leak. And you look at the bird and you say, I don't think so. And the bird said, really, it might. So you try it. And either the bird is right or the bird is not. So the only way to know if 18 with 330, 630, and 710 for the disc parts would be useful is to use it. And then you let us know, and we'll tell somebody in a course, and and then they'll try it. And then in 5 years or 3 years, it ends up in the advanced in a case presentation. Oh my gosh, we have some of the coolest case presentations coming in the advance. I'm so excited.
Awesome. Okay, cool. I have to interrupt. I have to find that question. I have to keep this train on the tracks. Question submitted by Katie Jackson. Child with cerebral palsy that cannot handle her secretions. It says due to dysphagia, but I'm thinking it says due to.
Due to dysphagia. Okay. So there's, I had the same question from one of the docs at Cleveland Clinic or Cincinnati Children's, someplace. Same thing about cerebral palsy. Kids with cerebral palsy drool. So he said, is there a frequency we can use for the salivary glands to stop salivary secretions? Well, is excess saliva actually the problem, or is the problem that the tongue and the swallowing mechanism is not coordinated? Because normally we all, like if you feel your mouth right now, you've got saliva in there and you swallow without even thinking about it. Kid with cerebral palsy can't do that. So what coordinates swallowing? Right? It's the vagus. So you want the vagus to work better. If you think about the pathways affected in the brain, the motor pathways, the loss of descending inhibition that's present in cerebral palsy, could the vagus be involved in the like in the spasticity that's in the neck? Is that doing something to the vagus? So I I would aim for increasing secretions in the vagus to see if you can get them to swallow better. Treat scarring in the vagus because they have so much spasticity in the neck and trunk. Then you yank on the vagus and you're constantly creating adhesions in the vagus. So it's always got little nerve traction injuries going on. And this goes right over to, in the Q&A section, have you treated MS rigidity or foot drop successfully? And in cerebral palsy patients, on the patient with the salivary problem and the dysphagia, I would have one machine neck to feet with 81 and 10. And I can tell you from experience that takes 60 to 70 minutes. We have better luck with lower extremity, spastic diplegia. But I'd have one machine doing 81 and 10 neck to feet. And as the leg muscles relax, the challenge you have is you have to teach them to walk again. That's another conversation. But then I would have a second machine treating the vagus, the whole vagal, just well, maybe concussion in vagus, but vagal tone with more time spent on increased secretions in the vagus and scarring in the vagus, especially if the cerebral palsy includes the neck and trunk and abdomen, right? So you treat scarring in the vagus to get it to work, increase secretions and make them swallow better. And that's, I hope, because this is only the second time in 3 weeks that I've created this hypothesis. So we'll see if it works. MS rigidity is 81 and 10. Foot drop is another conversation. That's actually in the new 5-day course, Suzanne. If you haven't seen it, you might check that out. It's it's on that slide. It's what's foot drop, what causes it. It's reduce inflammation in the nerve, treat scarring in the nerve, and then increase secretions in the nerve. And that usually takes care of it.
Right. Question here. Can you recommend a frequency combination to stimulate osteoblasts?
Well, I'm assuming you're talking about osteoporosis. I think. And if you think about John Sharkey teaching us that bone is actually fascia, osteoblasts fill up the connective tissue with calcium. I'd go with probably acute or subacute fracture. Like it's not bleeding, so take out the hemorrhage frequencies from fracture, but torn and broken in the bone, increased secretions in the periosteum, 59 and 39. I have always just mentally or philosophically been afraid of running increased secretions in the bone marrow because the bone marrow is such a busy place immunologically. And it just makes me nervous. So, but then treating the vagus made me nervous for 20 years. So who knows what we're going to do in the next 20 years. But for right now, I just treat the bone, torn and broken, increased secretions in 59, 39, and 783, the bone parts. And then vitality, I suppose. And then just remember that osteoporosis is a long latency vitamin D deficiency problem or a chronic inflammation problem. So osteoporotic bone is always going to be inflammatory or inflamed. So reduce the inflammation, increase secretions, that kind of thing.
Yep. What you said.
Yeah.
One of the, and then Paula, we did the hypoxia. I haven't found I needed to run it longer than 4 minutes, but it works. The older an injury is, it just kind of makes sense. So you don't need it in an acute phase, but old chronic gross injuries, it's your friend. There was one more question I jotted down before we do our closing remarks. Where did it go now? It was actually going along the lines of arthritis. So when I saw the osteoblasts, so Oh yeah, osteoarthritis, any success treating it with FSM? Can't poke back what's gone.
Can't, yeah, that's, although David Murphy in Ireland
Mhm.
has a pre and post knee X-ray or MRI that shows cartilage in the knee regrowing. I'm not sure I believe it, but it's right there in black and white. You can see it. Osteoarthritis, there is an interesting condition because you have patients who come in with horrible, horrible x-rays and absolutely no pain. You look at the x-rays and you say, this guy is going to be on a cane or a walker, and you walk in the room and he wants to know, when are you going to let him play golf again?
Right.
It's like no pain whatsoever.
Yeah.
So the wear and tear on the joint is not so much the problem as the inflammation is.
Right.
Torn and broken and necrosis. And the one from the advanced 217 ankylosis in the periosteum. So if you think about osteoarthritis and Wolff's Law, we think of osteoarthritis as being bone spurs, right? You have inflammation in the bone and the disc and the joint, and that's what makes it painful, is those bone spurs in the joint.
Right.
But it's not.
Right.
Right. Bone spurs, Wolff's Law, if the tendon is tight, if the muscle is tight, the body will build a bone spur to reinforce the tendon that's attached to the periosteum. And why is the muscle tight? Because the facet joint or the disc is inflamed. So the problem started 15 years ago when you had that auto accident or fell down the stairs or had the skiing, whatever, or you decided that golf was going to be your game. That's another conversation. And so you had the facet or the disc injured. That made the muscle tight. The muscle pulls on the periosteum for 5 or 10 years, and now you have a bone spur, and they call it osteoarthritis. But what was the problem? The original facet or disc. The question is, can you reverse it? And the answer is maybe. We can almost always reduce the pain just by treating the inflammation, treating the original disc or facet, treating torn and broken in the tendon, treating calcium, 91 and 217 in the connective tissue and the periosteum, and giving them little teeny exercises to get the little teeny muscles to move. And if they move, then the body will reabsorb the calcium.
Right.
Okay.
Right. So last little part of the question here before we go, it says 4 days ago, I'm not sure if that's part of it. How can this work for scoliosis?
Well, it would help if anybody knew why scoliosis occurs.
I was just going to say, it depends if it's functional or structural scoliosis. So
right.
I see a ton of teenagers that get flagged for scoliosis at their well child exam that their pediatrician send me, and it's functional because they put a backpack on one stinking shoulder because it's cool, and they walk around like this. So how can this work for functional scoliosis? Well, you have to figure out, is it true rotoscoliosis where the vertebrae are rotated, or do they have functional scoliosis where they have paravertebral fullness on one side? Because I've seen the well child exam and it's just a standing flexion test, and they're looking for paravertebral fullness on one side of the back. That's it. That's their flag. And then they have scoliosis, and that's not true. So again, why is it tight on one side? What are they doing? We're not looking at discs in a 14-year-old, but you have to loosen the tight side and strengthen the weak side. And then the structural stuff is a whole other ball of wax.
The neurologic part where they are at, I don't know, 27 degrees of curvature at the age of 19, that is neurologic and nobody knows where it comes from. There's some chiropractor someplace that said it was all because of the ankles or the C1 or whatever.
Right.
And it's with scoliosis, like true scoliosis like that,
Yeah.
I treat the facets and the discs, and like you said, get the muscles to balance and try and make them, if the curve is solidified. I mean, if they're adults now and they come in and they're 32 and they've got a 25 degree or 23 degree scoliosis measured on x-ray.
Yeah.
And you can't change the curve, but you can make them more functional by doing exercises and maybe a heel lift and maybe treat the facets and the discs so that you can have a scoliosis and not be uncomfortable.
Totally. Yeah.
Yeah. Okay.
Great. Because who really cares what it says on an x-ray if you're living without pain and you're quite functional? I think people get really caught up with imaging. I get a lot of people come in, they're like, look at my MRI, look at my x-rays. And I'm like, well, you're 72 years old. This is exactly what your joint should look like. How's your pain? Oh, it's not bad. Let's just throw this out then. So
the ones that I love are they bring in their imaging and I said, oh my gosh, I would kill to have a neck that looked that good.
Right?
Yeah.
And then they feel good and you're just like, oh, there you go.
Yeah.
It is 5:00.
We did it again.
We did it again. We got a lot of great questions answered. So keep sending them in. Kevin put a jot form together. So there's even easier, better ways of submitting your questions. Again, you can find us on Instagram, Facebook, YouTube, Apple Podcasts. So we are everywhere.
And it's frequency specific podcast.
Correct. Yes.
Yeah.
Yes.
Cool.
So yeah, and you can post questions to YouTube also, Kevin said. So you can send them all different ways.
And we will just have a great time answering them.
We do.
It was really fun.
It always is. And I will see you in person tomorrow.
I can hardly wait.
And we'll have a whole bunch of things to catch up on. So thanks everybody for joining us, and we'll see you all next week.
Do good things. Have a good time. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.